Yes, start. Hi, everyone, and welcome to this Case of the Month session. I'm honored and incredibly privileged to have two of my best friends, Dr. Andrea Baldini from Italy and Dr. Abtin Alvand from Oxford. Two revision surgeons, incredibly talented surgeons, but at the same time, academicians. They have taught me a great deal, and I'm sure you're going to learn a great deal from them today. The case we're going to describe to you is really trying to highlight a lot of the challenges you face in your practice. So this is not something about heroism or it's trying to tell you how great we are. It's really trying to tell you that the challenges you face in your daily practice, we also face in our practices. And together we can move forward with the right things. So the case I have is a 52-year-old lady who's had about 6 or 7 prior operations. And she now has pain in the knee and inability to weight bear or walk around. So she comes to see us, and this is her x-ray, but she does have a sinus tract, active sinus tract that drains a little bit of fluid every day. So first of all, this is her x-ray. First of all, I think all of you can see that she's undergone a prior fusion of the knee. And I think all of you can also see that the tibial portion of that nail is broken. Correct? You can see that, Andrea, Apton?
Yep.
Yes.
No
yes.
problem.
Very well.
Okay. So there it is. The question is this patient infected? The answer is doesn't matter what diagnostic criteria you use, a presence of a sinus tract that communicates with the implant is indicative of infection. Do you agree, gentlemen?
Yes, we do.
100%, yes.
Okay. So yes, sinus tract is present. So this patient is infected. You don't need a bone scan. You don't need anything else. This patient is infected. But we don't know what the organism is. So, Andrea, do you ever culture a draining sinus?
No, I think it's a mistake by two. First of all, you get everything that is coming from the outer compartment, so it's contaminated by the microbiome of the skin. Second, you have a name of something that may be useless, and then you have to justify to all around the patient's family, doctors, that treating that name is really wrong. So I think you have two problems if you get that culture.
So you don't do it. Apton, do you agree?
Same, it just muddies the water and gives you other bacteria that may have not been relevant to your organisms, that may have not been relevant to what's really deep in the tissues
So the
inside.
ladies and gentlemen listening to this, please know that the experts feel that you should not be sampling, swabbing a draining sinus. We and others have published on it. This is the publication, a multi-center study in the United States. And basically what it tells you is that the information you get, exactly as Andrea and Apton articulated, can be confusing because you're looking at a skin microbiome. You might get an organism and the patient may not be infected by that organism that you isolate. Okay, so do not swab draining sinus because the organism isolated could be skin contaminant. So this is the ICM Academy, the criteria. Apton, you know this because we worked on it together when you were in Philadelphia. All right, patient is infected. I don't have organism. So what do I do next?
So we've got to see if we want to biopsy the knee or aspirate the knee to get an organism.
Perfect. So I aspirated, and I only got one drop. Andrea, what do I do with one drop of fluid from the knee?
Yeah, first of all, it depends if this drop is bloody or not, because my in-office test is leukocyte esterase is great, but of course, if it's bloody, you cannot have a really reliable results. Everything becomes violet because of the blood. So the ideal is having in the office the possibility of doing a a separation of the fluid. If you
Mm.
have the machine that you can do it even in your office, then you have a clear fluid to examine on the leukocyte immediately after few seconds or minutes in your office. If it's bloody, of course, it depends if it's enough to send for DNA for a NGS detection,
Yes.
if you can. Otherwise, we can use it for other molecular testing, like calprotectin and alpha defensin, but the the flow test, the lateral flow test, again, if it's bloody, can be misleading.
Yeah, and to your point, here we know it's infected. So
Yeah.
fortunately, we don't need any other confirmation of an infection, but we need to see what we could do to be able to help. I mean, Apton, do you sort of do the same thing as Andrea, or do you have a different
Yeah,
philosophy?
no, we've following my time with you guys, I saw that it's very, very affordable and cost effective to have a leukocyte esterase machine test, and that we've got a small centrifuge which is like £50 you can buy off Amazon, and and then you can do the leukocyte esterase test, and both in the office, and we have one in the OR as well, and we use on sometimes during the cases when we need to know whether we're going to proceed with a 1 or 2 stage, etc. So we do that. But as you said, it doesn't really give you the organism. That's the problem.
So do you ever, either of you, ever infiltrate saline into a dry joint?
No.
I do not. In these arthrodesis, aspiration is very demanding because all the tissues are attached to cement.
Hmm.
So biopsy is really probably the only thing you can rely on. All the other knees are possible to be aspirated transpatellar tendon. If you get into the notch with the patient in the seated position, I always get enough fluid from
I
that
agree.
area.
100% agree with you, Andrea. That's the same. I always tell the residents when they come and say, I couldn't get a fluid, I say, that's impossible in a knee. But to
Yeah,
your point, though, with our arthrodesis, there's so little space and everything's tethered down to the
yeah,
to it. I tried this myself, believe it or not, and I could get maybe 1 or 2 drops. And they told me that's not enough for NGS, that wasn't enough for culture. So unfortunately, now I have a situation, dry tap. I don't have the organism. Patient is definitely infected, a complex case. I think we will all agree this is a complex case. So the options are obviously you can aspirate under guidance. I don't think that's going to help. I mean, Luigi Zagra has published from Italy that he has a fantastic ultrasonic guy, a person that helps him with the locating fluid. But in the knee, there was really no fluid. And by the way, the sinus, draining sinus, is part of the reason why there's no accumulation of fluid in the joint. That's
Yeah.
usually the case. So what would you do, Apton, under the right now? Would you try an aspiration under guidance, or would you go to open biopsy, or would you do something else?
Good question. It depends on the support you have and the radiology team. So we've got a very good interventional radiology team. So we've not had to do too many open biopsies. They do an ultrasound guided synovial biopsy. So they would take a Jamshidi needle and take a large amount of tissue that you can send off for both histology if you weren't sure whether it was infected or not, and also obviously for MCNS, and obviously if any molecular tests. So we would do an ultrasound guided biopsy. If I didn't have a radiologist who I was confident could get a nice synovial biopsy, then I would go take them to theatre myself and do an open biopsy.
Before I ask Andrea what he does, can you tell me where would you biopsy in this patient? Where would you tell them to biopsy?
I would do it based if it's an implant. If there was an implant, an actual knee replacement in there, I would ask them to do it either at the area of where there might be some lysis or at the implant bone interface at that area. In this scenario, obviously there is a fusion nail in, so I'd probably look to do it just below in the actual bone, because you want to try and get something rather than just some cement.
And there's actually also a little bit of collection there. I will show the X-ray again in a few minutes. So, Andrea, do you have access? What would you do in this situation? Do you have access to specialized imaging, etc.?
We can do a CT scan biopsy. We have a tumor unit across the street, but in this case, probably I would go ahead and redo a static spacer with a multitude of antibiotics covering all the wards of gram-negative, gram-positive, and fungi, and do the biopsy intraoperative.
Got it. Perfect. Perfect. So, I mean, I think you both have covered it beautifully. Your options are biopsy under guidance, CT, ultrasound, or even radiograph fluoroscopy, or open biopsy to obtain tissues and send it for evaluation. So basically, I think all of us agree that now to have the organism in this situation is important. So I don't have access to specialized imaging here in Istanbul. I mean, we do, but I haven't had the experience. And this patient was having problem with the knee unstable. I thought, okay, why don't I go in and take out that broken piece, obtain tissues from where you were talking about, Abtin, that upper tibia had actually quite a bit of a collection inside. As soon as I removed that broken piece, there was a collection of pus. So I was able to send that, multiple tissues. How many samples do you gentlemen usually take, culture-wise? 5. Andrea?
Yeah, 5 in this case is if I need the germ, 5. Otherwise, otherwise I may stay with 3 if I already have the germ, or if it's an obviously aseptic case.
Okay, and then all of those samples go separately for culture, right? You don't throw them all in. Okay, same with you, Abtin? Okay, so
Yeah, clean instruments each time separately, and we send for histology as well.
Yeah, because you're trying to really just increase the chances of obviously isolating the organism. So you're trying to do this in 5 separate steps.
That's right.
So we did. And let me ask, Andrea, how long do you keep the samples in these cases?
12 days.
12. You, Abtin?
12 to 14 days. So we call it extended cultures.
Yeah. ICM is recommending 14 days now. I did. We kept it for 14 days. Actually, we went to 21 days. I know this is in Turkish and none of you may understand, but it says basically no organism isolated. Culture is negative. However, I also send these samples for NGS at the moment, and I've been doing that for the past 10 years or so as part of research, but I also send it for next generation sequencing. NGS is next generation sequencing, and now there's a lab in Germany, and I have no conflict of interest, by the way. I'm just telling you that there's one lab in Germany that I send them to. Here at Oxford, you deal with a lot of funny organisms, Abtin. Have you ever heard of this organism before?
No, I can't even pronounce it.
Andrea, have you heard of this organism?
Never.
Yeah, I hadn't either. And here's the thing. A lot of the incredible infectious disease colleagues that we have, I reached out to all of them, and none of them had heard of this organism. So I thought, maybe this is a contaminant, but it's actually unusual because it's 99% single organism. So we thought maybe this is real. It's a fungus, by the way. It belongs to a species called Acremonium. And I will come back to that in a second.
So Jay, just for the crowd who may not be used to the actual readout from the NGS. So that 99% is basically telling us that this is not a polymicrobial infection. It's solely a fungal
one
infection.
organism. And 99% of the DNA of the pathogens they isolated belongs to one species.
Yeah.
And that's this particular species. So, Andrea, do you use molecular techniques?
Yes, particularly in these cases where you want the germ, you don't have data. We do it routinely. Routinely, we use the film array with a pre-constituted pattern. That means a fungi and staph AP. Fortunately, if it's not growing anything in our lab, they can deepen the analysis and do it sequentially afterwards if we have no bacteria and high suspicion.
Oh, that's
So
fantastic.
we do it
But
as a second level, the
I got
DNA.
it. They save the samples. That makes
Yeah,
total sense. Total sense.
because
Because I mean,
the cost change a little bit
yeah,
also. Yeah,
exactly. I was going to say, because cost is an issue. You can't
yeah,
really do this for everybody. And plus, in some of these cases where the index of suspicion is really low for an infection, you don't want to send it for molecular technique, maybe, because you will get an organism that
yeah.
could be part of microbiota. That makes total sense. Do you do the same in
We
Oxford?
we do the same, yeah. So we start with routine microbiology and culture, and then the ones that we don't manage to grow, we've got the samples still, and we have to send them out. And obviously, the cost is slightly more, but it's worthwhile in those complex cases, especially the culture negatives.
Yeah. So we asked and answered this question during the consensus, as you both gentlemen know from the consensus. Pierre Randelli was in charge of it, and they did a systematic review. This is related to hip and knee PJI. And their conclusion, with a very, very high agreement, was that yes, molecular techniques are good adjuncts that help, and particularly in cases where it's culture negative. You know it's infected, but you're not isolating the organism. So important in those cases to rely on the molecular technique. Which one you use depends on your lab, your facilities, your access to them, your patients' access, etc. But yeah, so here's a little bit of a twist I want to tell you. Then we looked through her documents to see if ever any organism had been isolated in Iran where she was treated. And one of them was a Staph aureus. But interestingly, in one encounter, they had this organism isolated from culture, Acromonium species, colonies grown. The results of two consecutive sampling and cultures are the same. So this gave me, and this is, by the way, identical to what that NGS isolated. So now I think all three of us would agree that this is real.
Yeah.
Do you agree?
Yeah.
This is real.
Yep.
I assume this is real. And by the way, they've done a bone scan, and that's where the area of collection is we were talking
Yeah.
about in that tibia. So you would have probably picked that up on the X-ray as well. So I thought, there we are. We've got an infected patient who's had multiple operations, fused, but the nail is obviously broken. So now we're dealing with a fungal PJI. Okay, Andrea, what
Yep.
next?
You have done a partial opening of the case, but the bacteria is still there. So you have the germ. You can have the same success of having one versus two stage. Of course, we don't have too much experience on multiply operated legs with one stage. Even the new papers coming on, the one stage cases are more straightforward cases than this one. So I would be a little bit. This is the case where I do a two stage, even if I'm switching more for a one stage.
Okay, but it's interesting, but you're choosing reconstruction at this
Yeah.
situation, right?
Yes. Yeah.
And the same, Abtin, would you do
Yeah,
reconstruction?
I think there was enough bone stock there, and the extensor mechanism seemed to be intact. And I presume the patient's come to you because she doesn't want an amputation, otherwise she would have maybe had it somewhere else. So I think a revision procedure is indicated. Whether I would go for a two or one stage, maybe 5 years ago, 4 years ago, 3 years ago, I'd be 100% two stage with a fungal case like this. But now, having seen a lot of the patients with the interstage issues and the functional outcome, and the patient just saying they've had enough, I'm tempted sometimes in these cases when I've got an organism, even though it's a fungus, to maybe lean towards the one stage. But that would be a discussion with the patient. And as Andrea said, although there are really good results from the American RCT, and also we did one in the UK that one and two stages similar. There's a very little data on the multiply revised infected cases. So this would be probably a multidisciplinary meeting with the infection team to see whether they do have any local antibiotics that you could put in there for this organism, and whether we think that it's a treatable organism, how difficult is it to treat. If it was, and we did have something that was cement stable or other local antibiotics carriers that could be used, antifungal carriers rather, then there may be a role for considering a one stage with radical resection and debridement. So that would be my thoughts.
So I think you both highlighted important. First of all, the extensor mechanism is intact in this patient. The patient is young. And amputation in this part of the world is an absolute no-no. People will not want that. Maybe her option would have been another arthrodesis. But she also has good bone quality. And I think there may have been some areas for improvement of her care. I mean, it's possible, as far as I can tell, she never received an antifungal treatment previously, for example, even though they had isolated the fungus. So I sort of felt that there were areas where we could really, really improve and give this a shot. And of course, patient doesn't want a fusion. But the point that you important, and that is obviously patient's wish, etc. On top of that, is there an extensor mechanism? And can you do things a little differently to improve the outcome? And I felt that there were things that we could do better that could potentially give her a better outcome. So I decided that we would go for a one-stage exchange. I'm not saying that's what you should do, and you both bring out very good points. If you're familiar with two-stage exchange, it's absolutely perfectly fine to do a two-stage exchange in this situation. But I decided that I wanted to do one-stage exchange. Now, interestingly, the U.S. trial that you mentioned, I don't know about the UK Swedish trial, Abtin, but the U.S. trial, we excluded fungal infection for one-stage exchange. That's the only thing we didn't include. But most people, and this was a stuff during ICMS, but most people don't really want to do one stage for a fungal infection, which is understandable. That's why I think Andrea's and your point about doing a two-stage exchange is perfectly fine. But I think the three of us agree that it is worth giving this patient another shot at reconstruction, correct?
Yeah, correct.
So that's what we did. We did a one-stage exchange for her. So what do you do with a one-stage exchange in terms of antimicrobial treatment?
Yeah, 3 months antibiotics. And nowadays we are using also intra-articular catheters. I thought was logistically difficult. Instead, we had experience very recent, which is probably something very promising in these terrible cases. I'm always skeptical of working through catheters around prosthesis. In particular, we are doing when we are dealing with tumor prosthesis or very big hardware, and these could be one of the case, for example, at least for the first 2 weeks.
Actually, I learned this from Shao Li in Urumqi, and I think Shao Li does the highest number of infected cases in the world. I spent some time with him. And one thing I took away from that, Andrea, was that they felt that the local delivery of antimicrobial makes a huge difference in their practice, particularly to your point about antifungals, because the therapeutic window for antifungals is narrow. You can not give too much antifungals, you will cause liver toxicity, etc. So in that circumstance, maybe giving locally is important. So for the past couple of years I've been here in Istanbul, I always leave a Hickman catheter behind in these infected cases and deliver local antimicrobials. We can talk about that another day, but I think in this situation, I decided to leave a Hickman catheter behind also. Abtin, do you have much experience with local delivery? I know you obviously have these, Martin McNally published a paper about local delivery of antimicrobials using polymers and resorbables, etc.
Yeah, so we do that. We don't do catheters, but it'd be interesting to see how you practically do it and whether you have any issues with blockage, etc. But we try and give, obviously, in the cement, it's a no-brainer. You could add it, but as we know, it doesn't elute as long, so it, works only for a few days. But so we use antibiotic carriers, local antibiotic carriers, calcium sulfate beads, like Stimulan, for example. And then there's different ways. It's off-label, really, because they're not really licensed. So they're only licensed for a couple of antibiotics, but you can add anti fungals to them, and it takes a lot longer for the calcium beads to set. And we deliver that. I deliver that inside the medulla, so intramedullary. I put it up the canals, up and down the canals, and then I leave some in the joint as well. So I try and reduce the amount I put in the joint because it causes some leakage. So and some increased fluid leakage from the wound. So I mainly put a lot of it into the intramedullary canal. It's the same as, for example, maybe giving intraosseous antibiotics like
Yep.
Mayo.
Yep. So that's what we did. And then with the one stage is minimum 6 weeks. That was discussed during the consensus, but maybe more towards 12 weeks. That's better for one stage. And then, but you have to remember, fungal infections are different. The IDSA Infectious Disease Society of North America, as well as EBJIS, recommends 6 months of treatment minimum, which is what we did with this patient. We left the catheter behind for 1 week. Every day we give an antifungal. I actually have a patient I operated on yesterday. She's receiving antifungal. She came from Kuwait and she has similar type of a situation. So antifungals for 1 week, and then that helps. And here's a surprise. It's amazing. This patient actually did fairly well. Initially, Andrea, she was having a little bit of hyperextension on that side with that hinged knee, was worrying me immensely. This is actually 6 weeks out from her surgery. I know you talked about that in the revision knee. She has not had a quad strength for a long time, so I blame the quad weakness, and she has improved. But should that have worried me that she was having hyperextension, Andrea?
Typically, this design, after 30,000 cycles, it moves from 3 degrees industrial hyperextension stop to 9 degrees. When it reached 9, it doesn't progress too much. So they stay around 9, 10 degrees, which is to me a little bit unacceptable, but is not a failure. So this is the reason why this design to me, with a poor capsule or a poor extensor mechanism, is suboptimal. Is very good for wear and for all the rest, for dissipating joint stresses around the stems. I think it's great, but for extension control is not fantastic.
I've learned from you immensely, and I remember talking to you in Belgium about this issue of hyperextension. Thank you for making that so clear to us, that this is design dependent and you can do things to try to prevent that. I can't thank you, the two of you, for making time. We're trying to make these only 30 minutes. We're exactly 1 minute away. Any last minute messages for our audience? And I don't know how to thank you for giving us your time and your dedication, gentlemen.
Thank you, Jay. Just one brief comment. Fixation. When we are going for fixation in these cases, is always worrisome, because we don't want to do under fixation, but we don't want to do over fixation, because in case they fail, you have to remove it. So deciding which is the right amount of fixation in this case is where the canals were already utilized, is always very difficult. Now we talk about very techniques, but this is a very difficult topic with bone impaction, cones, only pressurized cement. So I think here you use the reasonable fixation for a young lady. In case of something happens, you can remove the implant.
Yes, and it was a hybrid fixation, to your point.
Yeah.
I tried not to cement these very, very long prostheses. If you're going uncemented, I've learned from my literature and from you, Andrea, that if you're going uncemented, you have to go long. If you're going cemented, go short. Even for a hinge, you don't have to put a 200 millimeter stem. But thank you for that very, very excellent point, because it will be a very long day in the OR if that case fails and you've got a long cemented stem up and down the knee. Very,
Yeah.
very valid point. Abtin, any
Yeah,
last
so
words?
don't burn your bridges, because sometimes these patients do come back. So you need to be able to live to fight another day. So the same as what Andrea said, I go long, cement less in some of these infected cases so that I don't have to dig out a mile of cement a few years later.
Gentlemen, exactly on the dot. You're incredible. I always learn a great deal from you. I cannot thank you for your friendship, your dedication, and for giving me half an hour of your very valuable time. I'm sure our audience would have enjoyed this. Have a great day, and thank you. Aptin, go back to the OR.
Thank you.
Thank you,
Thank you,
Jay.
Take
gentlemen.
care.
Thank you.
Bye-bye. See
Bye-bye.
you.
Bye bye.
Bye. Bye-bye.